Yes, yes.
Good evening, everyone. Welcome to International Society of Small Incision Cataract Surgeons US chapter launch.
Yes, yes.
And we have a joy and a
Mm.
galaxy of experts in the field of cataract and refractive and many other specialties here today. So let's not waste the time because it's a jam-packed program. Please stay till the last minute because we have interesting speakers, including Dr. Suhas Haldipurkar at the last minute. So none of us want to miss any videos or any talks from this galaxy of experts. So I now request our founder chairman, Dr. Amulya Sahu, to please give his opening remarks. As Dr. Boni Anderson said, ISMSICS has created a history. It's a great movement which is being done with most of the countries now having or developing or they are trying to go ahead with more and more of surgeries of small incision cataract surgery. So I now request Dr. Chairman, Dr. Sahusan, to please give his opening remarks.
Thank you, Srinivas. It is really an honor to be with some stalwarts all over the world. And ISMSS, as you know, in last 1 month we have made about 3,000 members in India. 3,000 members. And so it is going in a round, and we are opening chapter in Brazil now. NATO will be there. He has done a wonderful job, and he has made up his team. And Boni, I have been testing her, and she has been such a sweetheart. So she has always been there and promoting SICs and telling I am a novice all the time. So that is not fair, and I have been a part of your course. So please don't tell that word again, because you are really inspiring, because you have been carrying on this process in American Academy and ASCRS.
Hello.
So
Yes.
please at least stand up for the SICS, say that yes, is there to come to stay. With Jeff and Sudan, all these people are really in a lot to the SICS movement. Because
Okay,
SICS is definitely here to stay, and it is balancing the whole lopsided development of network. Because we are 70% of Indians are doing it, and now we have come to
Yeah, I already changed. I
level.
already changed.
So different level
Because there are
we are
17 users on 12, 13, 14, 15 users are there.
conference. So with American chapter, this is I'm giving it only without
Okay.
I'm forcing you to. This is the now I am trying to give you all these people, get them together. I am
Okay,
working in
okay.
that level because people are very busy, don't get time for spending this kind of thing. But I'm not going to spend. So I will tie you all together. Jeff has been a component of SICS for a long time, and Sudan, I came to know she has a lot of interest in Africa where the SICS will do a good job. So we are looking forward to a lot of thing in the SICS front. Thank you so much.
Thank you, Sahu sir, for those quick comments. And now I request our chairperson of ISMSIC Society, Dr. Jagannath Boramani sir, to please say a few words.
Yeah, I welcome all our international faculty outside India as well as the Indian faculty for this wonderful webinar. As Dr. Boni said, we started the movement of SICS in the world. We could easily make way in the Southeast Asia, but it is very heartening to know that you people from the Western world also have taken over the mantle. In fact, Dr. Boni has written a beautiful book on SICS, in spite of being an accomplished surgeon. So it is very heartening to know that the Western world also is interested in learning this beautiful art of SICS, and your extreme cooperation is expected in the ISM SICS movement all over the globe. Thank you very much.
Thank you, Dr. Boramani sir. And I think without wasting time, I'll just introduce our panelists we have today. I welcome all the speakers on behalf of ISM SICS Society, the President, Dr. D. Bhattacharya sir, our Vice Chairman, Dr. Parikshit Gogate, our Chief National Coordinator of ISM SICS, Dr. Satanshu Mathur. And here joins Dr. Jagdish Reddy Bandi, my co-moderator, a very young, dynamic surgeon, director of Ishwar High Hospital, is a research fellow of glaucoma from University of Miami, involved in various cataract surgeries training program in Ghana. So I request Jagdish to please switch on his video. And quickly, we have the panelists. We have here is Dr. B.K. Nayak. I think he's yet to join. And once he joins, I'll introduce him. And we have I call him as one of the Bhishma Pitama of All India Ophthalmic Society, who is none other than our Vice President of All India Ophthalmic Society, Dr. Lalit Verma. He has literally changed the way the scientific programs being conducted at the All India Ophthalmic Society. A very innovative and down-to-earth personality. Thank you, Dr. Lalit sir, and I think he has given most of the sessions to ISM SICS in the All India Ophthalmic Society. It's a conglomeration of more than 15,000 ophthalmologists attending in the 4-day conference. So, he's now, we are lucky that he's now the Vice President of that prestigious society. With that, we have other panelists. Dr. Santosh Honavar will be joining soon, and now we have Chinmay Sahu. So he's none other than Dr. Amulya Sahu sir's son, a very humble and always approachable, down-to-earth personality, like father, like son. I'd like to call him. Welcome, Dr. Chinmay Sahu, for this ISM SICS international webinar. And we have Dr. Carla Pamela Gonzalez. I think she is now the host of ISM SICS Society conferences being conducted in India. And thank you, Pamela, for joining. And she's been a constant supporter from Mexico. Thank you very much for joining us today. And then we have another ever-smiling personality, Dr. Zubair Ansari from the University of Miami. We are lucky to have him also in this international webinar. Thank you, Zubair, for joining us today.
Pleasure to be here. Thank you.
And then we have Dr. Hansen. I think he'll be joining us very soon. And before I quickly go to Lalit sir, our president of ISM SICS Society, Dr. Debashish Bhattacharya has joined the meeting. A few quick words by you, Dr. Debashish sir.
Good evening, Srinivas and everybody here. It's been a great gathering, and it will be a huge learning experience for all of us. Looking forward to the webinar, and all the best. Carry on, Srinivas.
Thank you, sir. So I now request our first panelist to make his comments, and then we'll go on quickly with the talk from Dr. Boni Henderson. Dr. Lalit, sir.
Thanks all the office bearers of this great society, ISMSIS, for having me here in this grand international webinar. We have 7 international speakers from US, Russia, Brazil, Israel, and so many other places, and 7 of our own stars also. You see, honestly, I'm not a cataract surgeon, but therefore I feel myself to a misfit in this webinar. But in any case, as chairman of All India Ophthalmology Society of the scientific program, I realized that SICS is a magic. Therefore, that is the reason I kept a lot of sessions of SICS and named this as Magic of SICS. And I believe that this is the answer for the global cataract blindness. And all of you, I think, will agree with that. You see, I personally feel that all cataract surgeons must master this wonderful art. And even the most experienced phaco surgeons will, at some time or the other, be required to do this, howsoever proficient they may be. And it has a lot of advantages. People all know that. Apart from the cost factor, there are a lot of other advantages also. And most important is that it is non-inferior to phaco. You see, even in government circles and ministry, we keep talking. We should talk about cataract surgery. We should not talk about phaco or SICS. And so we get insurance reimbursement. That is one thing which I feel should be done at AIS level also. And it's believe me, it's a savior for a lot of cataract surgeons also. So without talking too much about it, I personally feel that SICS today has become a phenomena, or as Dr. Boni said, it's a movement. And it has national, state, and now so many international chapters also. And very heartening to hear Dr. Sahu telling that so many Indian ophthalmologists have become members. I think this movement should go on, as Boni said, and I will request all of you to work so hard that should not sleep till in all 194 countries we have some chapter or the other. All 194 countries of the world. That should be our aim, and we keep working. I'm sure Joshi has so much of energy into it. He will tire himself to meet this objective. And all the cataract surgeons should learn this technique, this wonderful technique. With these few words, I think all the very best to all of you for for this great webinar. Over to you, Srinivas.
Lovely, sir. Thank you so much for your words of support. We really mean every word of it, and I'm sure that we'll try our best to do for our international expansion as well. Thank you, sir. Thank you very much for your words of wisdom. So, without wasting much time, I hand over to Dr. Jagdish. Dr. Jagdish.
Hi, it gives me pleasure to invite Dr. Bonnie Henderson, who is the chairperson of the Ismsics US chapter. She's the past president of American Society of Cataract and Refractive Surgery, and she is the professor at Tufts University of Medicine and also an associate editor for the Journal of Refractive Surgery and the Eye World. She has published many textbooks and has been authored many papers and books. And now I present you Dr. Bonnie Henderson. Over to you, Dr. Bonnie.
Well, thank you, everybody. And again, good evening over there and good morning in other parts of the world. I'll start sharing my screen as we start chatting. So I just want to say, first of all, thank you to everybody for creating this, and especially our fearless leader, Dr. Thap, who has really popularized this. And
Dr. Bonnie. It was an excellent video. And really, for all those cataract surgeons who are anterior segment surgeons, it really would be helpful. We always have the fear of actually that the IOL might fall down when you're using this iris claw lenses and even the three-piece IOL, these techniques. Probably Dr. Devashish and Dr. Lalit Verma has something to say about this. They're pretty experienced in all this. Dr. Devashish, sir.
So Bonnie, I have to say, this is not a simple little contribution. I think this is major, and it's going to allow surgeons who would never even consider using this technique or learning it because they're so afraid of having a complication. It's allowing them and allowing us to teach people how to do it as well.
Sure, Dr. Susan. Now we'll go ahead with the talk, and we have none other than Dr. Susan for the next talk. She is the Associate Clinical Professor at the Tufts School of Medicine. She's the president of ICOPS, and she has done a lot of work going on in sub-Saharan Africa. She was talking the other day. It's a great work, Dr. Susan, and then she is the resident co-director of the Lahey Clinic, and she also won the Teaching Excellence Award from the Tufts and a cataract surgery trainer. Over to you, Dr. Susan.
Thank you. I'm going to share my screen, and I hope it doesn't show how incredibly cluttered it is. But can you see my screen?
Not yet.
Okay, let me try this one more time. Zoom. Share screen. Can you see now my mess?
Not yet.
Here it comes. Okay.
No, yes, you are. Go ahead.
All right. So I want to say thank you so much. I am delighted to be here, and I have so many comments, and I wish I could have like a half hour to thank all of you. order for us to provide care to the community and reduce global blindness. And so my apologies are straight out right there, and let's go on. So I want to talk to you about a combination of using technology and combining that with this beautiful surgical technique, and that's using the MyLoop. And the MyLoop is a gadget that was designed by Sean Ianchev, and it's a nitinol filament that is used to actually cut the nucleus into pieces. When I was in Tanzania with Alan Crandall, our dearest colleague and mentor, he and I talked at night a lot of times about creating a technique that we could also compete with this very small incision phacosurgery. And so we've started, when I was in Tanzania, we started using this technique of using the MyLoop. And this is Dr. Manas Nath we're doing a study in India right now. And we're looking at, we're going one-to-one on phacoemulsification training versus SICS training with the MyLoop and having a small incision. So you can see we're just doing a straightforward can opener capsulotomy here. This is a mature cataract. In many of these cases in sub-Saharan Africa, it's impossible to do a phaco in an efficient manner, and it's very difficult not to damage the endothelial cells. So here you see the loop. We're going underneath the capsule, and then we're expanding the loop. And once it's expanded completely, we're rotating our wrist to the right, and we're sliding underneath the nucleus. And then we're going to retract the nitinol filament into our instrument, but we're going to put a little more viscoelastic in, and we're going to hold down the nucleus, and we're going to snap it into...
Excuse me,
Dr. Susan, your video is not playing.
Yeah, only the first slide is seen.
You can't see it?
No, we're just stuck at the first slide.
Oh, can you see it now? Stop, let me see. Share, paused. Oh, it's share. Okay, here we go. Is this it?
We're just still seeing the first screen.
Susan, if you can stop sharing and then restart sharing, and when you share, make sure to click that you'll, in the bottom left-hand corner, there's a little video, optimize for video, and then select the PowerPoint, not your desktop when you select what you're presenting, and it will pull the PowerPoint up, and then we can see the PowerPoint.
Okay, Jeff, you're going to have to say that all again because I see.
Yes. So when you start sharing in the bottom left-hand corner,
share.
Click optimize for video, and when you choose what you're going to share, choose the PowerPoint, don't choose the desktop. You have to choose the actual PowerPoint presentation itself that's up, and then that will show your video.
Okay, share. Is that working now, guys?
Yes.
Yes.
Working. Perfect.
Okay, hold on. Is it working when the video works? rectus, I am able to gently bring these pieces out through a 4-millimeter incision. So the bottom line is, why is that important? And I truly believe why it's important is that there's going to come a time where we're going to be able to completely compete with small incision cataract surgery. I do not think the MyLoop it is not as expensive, and it does not require the bioengineering that a phacoemulsification surgery does. Thank you. I'm looking forward to your comments. I can't hear you.
You're on mute, Dr. Reddy.
Thank you, Dr. Susan, and that was a really nice video. And Dr. Jeff actually has a comment on it. Please go ahead, Jeff.
Yeah, I know in 2009 there was a publication by Dr. Bhattacharya, who is here, about the snare, and I'd be curious just what his perspective is on this version of the snare versus the one that he published on, and what role he sees this having for small incision cataract surgery.
I'm not sure Dr. Bhattacharya is over here, but okay, please go ahead, sir.
So essentially, MyLoop is costly. It's made out of Nitrilon, but we just make a snare out of the A1 string of the guitar with just a 20 gauge IB needle. We blunt it, and we made 2 side hubs, and the MyLoop, and then we thread the A1 string of the guitar. It comes out through one hub, and we take it and get it into the other hub, and that's how you create a lasso. And then we take another 20 gauge needle and you can put it there. So when you pull the second needle, actually the lasso closes. So it's a very elementary tool that way. And of course, because it is the MyLoop is made of Nitrilon, so it can be used over and over and over again. But this one is kind of a disposable technique, and it comes from the tip of the needle. So actually, we open the loop in front of the nucleus, or we go behind the nucleus. We cross the equator and then just turn it around. So we go and then turn it around. I hope I could have shown the video, but I currently don't have it on stock in my laptop. So it's another way of dividing very hard nucleus, because it's steel, so it can cut through any hardness of the cataract. Yes.
That's so true, Dr. Bhattacharya. Sir, we can actually share the video probably after this, and it costs less than $1 for sure. And then it's a great technique. And Dr. Gonzalez actually has a question for you, Dr. Susan.
Sure. Good morning. Dr. Susan, congratulations. Great talk and videos. I really enjoyed them. I have actually 2 doubts. Do you use the MyLoop when the nucleus is in the back, or do you luxate it first to the anterior chamber? And the second question is, how safe is it for the posterior capsule? Like, for example, for someone who has never used it, what would be your recommendation?
Right. So thank you for your questions, and thank you for this, the comments about the snare technique. So this technique is in the bag, which I think is very safe. And I will tell you, it's very scary the first 10 or 10 that you do, because you're absolutely right. It is not our nature to slide something underneath the nucleus in a blind technique. But it is a very safe technique. I've used this in pseudoexfoliation cases. And for me, the advantage of using this versus doing a straight small incision cataract surgery is really when I have a small pupil, because I have a very hard time sometimes getting that, and I would love any of you experts to help me with this. But when I have a small pupil and I'm trying to get the nucleus up into the anterior chamber, I really struggle sometimes. And I have found by using the MyLoop, once I've engaged the nucleus and I'm about 3/4 of the way cracking it, that if I flip my wrist just so gently, I can actually deliver the nucleus into the anterior chamber. And so I'm using it for a strategy that it is not designed for in that particular situation. But I have to say, it makes me a better small incision surgeon. So I would say this, thank you for your question, and you should not...
There's one more question, Dr. Susan, from Dr. Burma.
No, I have a small comment. Whatever Dr. Debashi said, long back, almost 30 years back, he started the concept of snare technique for nuclear. Yes, so 25 years back, he's written book on the snare technique. The concept is same. Only thing is that this requires little expertise initially to learn this technique, how to do it without damaging the endothelium and posterior.
Dr. Boramani, can I show a 1-minute clip of the video, Jeff?
Ask Dr. Jagdish.
Sure, sir. If it's going to be quick, get backed up. So please.
It's a great technique. I think one of the differences is one is inside, one is in the capsule. This is in the...
This is the anti-chamber.
You can go behind the lens also if you want.
And you know what? I think this requires dexterity for a surgeon than the MyLoop does.
Because the MyLoop comes from the... Yes.
Yes. And the other thing that I really want to speak up about, that the Gates Foundation, the Global Health Initiative Fund, actually invested in the MyLoop, and so this committed instrument is a reusable instrument, and then developing and low resource settings that they are making sure that it is going to have access to it. This is a lovely technique here. And you know what, sir? I would love to have your advice on the side.
I'll send the video how to make it, use it, and to all of you. Yeah, I mean anybody who's interested. Yeah. And
yeah,
Daniel and Shah in Dubai in Mumbai, and so this is how we teach each other.
Thank you so much, sir.
Wonderful.
Thank you so much, Dr. Debashi, sir. Now we'll go ahead and our next talk is going to be Dr. Jeff. Dr. Jeff is the Associate Professor of Ophthalmology and Visual Sciences. He's the Residency Program Director at the University of Utah, and he's the Chief of Ophthalmology at Salt Lake City Medical Affairs. He's published journals. His focus is towards post-traumatic anterior secondaries. Thank you, Jeff, and it's over to you.
Thank you, Fred and Honor. You can go ahead and start the video
Yes,
of the talk. Sure. And I do just want to acknowledge, first of all of you for advancing the surgery. And then this is a special honor for me. Bonnie Henderson very early on, and Susan McDonald very early on in my career, just out of training, both in many ways took me under their wing, and I owe much of any anything I contribute to ophthalmology to these two incredible women, and they all also have been incredible kids for women in ophthalmology in the United States and around the world. So in the place and time where who we are as a profession, these two have been vanguard. No problem. Thank you.
Good evening, good day, good morning, wherever you are in the world. It's an honor to be with you. I'd like to sincerely thank the organizers of this conference for advancing small incision cataract surgery and all types of cataract surgery around the world. My name is Jeff Petty. I work at the Moran Eye Center in Salt Lake City, Utah, where I'm in charge of education, training, and our global ophthalmology division. Excited to share with you small incision cataract surgery versus phaco. When should we use it and why? I have no financial conflicts of interest. Again, I mentioned I'm the residency program director. This is really where I live. You can think back to your original training and surgery. You trained in small incision or an extra cap form of cataract surgery as your first cases. Our residents in the United States and many other parts of the world, they train primarily in phaco. In fact, some of them never see an actual extra cap, either small incision or traditional large excision extra cap. And as such, it really creates a different dynamic for them. You likely feel most comfortable with small incision cataract surgery for your most difficult cases, whereas these residents will almost always feel more comfortable with phaco for their most difficult cases. And we call this your best pitch. Well, what is your best pitch? This is Aroldis Chapman. Aroldis Chapman is one of the pitchers for baseball, the New York Yankees currently. So Aroldis Chapman once threw a pitch at 146 kilometers per hour. His best pitch is always his fastest ball. Now, what about someone like Kapil Dev? Perhaps it was an in-swinger, but many might argue it was his outswinger that was actually his best bowl. And so you really have to think about it in terms of this as you start to look at cases. For cataract like both phaco and small incision, you might choose one or the other depending on circumstances. Whereas something like this, boy, I mean, what do we do? Again, something interesting. This is where we would definitely bring our best bowl. Again, something like this, perhaps you feel comfortable with phaco or SACS for a typical white cataract. But let's look at a couple of cases. So if I'm looking at this with one of my residents and I'm trying to teach them phaco, we're going to start something like this. I'm going to go through my paracentesis here to try and maintain the anterior chamber. And I'm teaching, showing, look, this is what you want to do. You don't want to dump the chamber. You don't want to have a capsule, anterior capsule tear run out. But if you watch right here, this really, really is unfair. Boom, that happens right there. And that was just an issue with technique there where we grabbed the anterior capsule and pulled out. So here in our operating room, we get some micro scissors. We cut around. We continue, complete the rhexis, and then we made relaxing incisions. Now, in this particular case, the best thing for us was to switch to SICS. So we, again, in turn, switched to SICS. You'll notice I'm sitting superiorly. You'll also notice that I have here a paracentesis that I'm actually making my scleral tunnel through. Now, this is something that can introduce some risk, but in this particular case, it was still going to be my best bowl to switch to SICS, and indeed, at the end, the sealed without problem. So as we continue on, you'll notice a few things. This is a smaller external opening. Many of you have likely already seen that. We still don't know how dense this lens is going to be. But again, as we're kind of moving through teaching, we're going to dial. We start dialing again, relaxing incisions in the anterior capsule in 5 different places to help release some of those forces, hoping to prevent a tear from continuing all the way around. And indeed, we were fortunate. We did not have a posterior capsule extension in this. So we continue on. Again, working with the resident, showing them this is something you can do. You just continue to dial. For many of you, this is probably very slow. But for a beginning resident teaching, this is again the speed at which we take this. Again, slightly small wounds, so just a little bit of extra lens material to come out. But in this particular case, we had an anterior capsule rent. There was concern for that anterior capsule rent to extend posteriorly. And in this particular case, that concerned a lens that was likely going to be very large. For me, for our operating room, small incision cataract surgery to convert was the exact right decision for us. So we're going to go to another case. This is a white cataract. Here, moving to our next case, this is a white cataract. Don't know exactly, is this really large? Is this liquefied? We're not entirely sure. But we're going to start actually doing small incision cataract surgery for this resident. This resident didn't make a great varosclera cut down, and you'll see what happens here. This patient is really moving. Again, this patient is awake. There was a block, clearly not a great block, and this patient continues to move. So this is where I took over and said, I need to bring my best bowl. I train primarily in phaco. This is my best surgery. So what I want you to really pay attention to, the left hand here is fixating the eye. And in fact, the rest of this case, there's never a point throughout the rest of this phaco where I don't have an instrument in the eye and my hand on the forehead or the cheek to control things. And in this particular case, I have two instruments in the eye. You see just a little bit of movement there. That was again managed because both of my hands were on the eye at this time. So we make a complete continuous capsulorhexis, do hydrodissection, hydrodelineation just as you would. In this particular case, I used more of a vertical chop technique to divide very small pieces off of this lens. And again, just continue to take these piece by piece until eventually we're able to remove all of the lens safely. Now you'll see as I come out with my second instrument, I leave my phaco tip in. I leave my phaco tip in until I can put viscoelastic in the eye. And then I'm going to actually keep this viscoelastic cannula in the eye the entire time. I want to keep the viscoelastic cannula in there to control this eye for eye movement. Now in comes the lens. I've got two instruments in the eye to control. I keep my left hand in. Now I come in with my irrigation aspiration handpiece. I've got good control here. I've got two instruments in the eye. We do our typical irrigation aspiration, remove viscoelastic. Now I can finally remove my left hand. I've got control still because I have my IA handpiece there. Do some hydration. Finally, at the very end of the case only, do I come out of the eye with my IA handpiece. Do a little bit of our hydration into the wounds. And then, of course, at the end, I do need to close the conjunctiva, and we tie that down. So for many of you, I would very much assume and guess that your best pitch is going to be, or your best bowl rather, is going to be small incision cataract surgery. And that is the surgery that you need to go to as your go-to. You're clearly taking this to new heights throughout the world. You may not know, but U.S. surgeons who have never done an extra cap or a small incision cataract surgery are really lining up to learn this surgery and technique to improve our ability to provide the best care and have the most pitches, an in-swinger, an out-swinger, hopefully not a beamer, but maybe a bouncer to be able to complete our abilities to be complete bowlers and complete surgeons. Thank you again for the honor to be with you. Look forward to someday meeting you in person. Thank you.
Dr. Jeff, that was an excellent video, and you were actually good with both of them. The phaco and the SICS, no comments on it. Definitely was great. And just wanted to, do you consider actually having on the table blocks so that you could decrease the movement or something like that, rather than taking it with?
Yeah, we do always have blocks available, and in that one case, we did a block. It wasn't a great block. It eventually did take hold and at least allow for paresis of the eye. The main issue there was with the patient just moving all the time. I still know for me, because I train primarily in phaco, I can control that eye. I can have hand on the forehead, hand on the cheek. I can move with the patient if they're moving, and again, that for me was safest. But for some of you, small incision may have been the perfect surgery for that particular patient. Perhaps you're taping the head, or perhaps you're not doing that surgery at all. That's also a very good decision at times, as we all know.
Thank you. I just wanted to know if anyone wants to comment on it. Dr. Ravindra, sir, do you have anything to comment on this?
That's a great strategy for a person who is not well, accustomed to doing SICs. And the subtenon block is something which is very good. We can supplement at any point of time. It's a great technique. If the eyes open, doesn't really matter. Take a appropriate curved cannula into the subtenon's place. You can go up to the muscle bone if you need to, but then inject 1 or 2 ml is more than enough. That will give a very good block intraoperative.
Thank you, Dr. Ravindra.
I think, Jadi, we'll move on to our next speaker, Dr. John.
Yes.
Welcome, Dr. John. Dr. John is the attending physician on the cataract and primary eye curve services at the Wilsey Hospital. He has a particular interest in actually multifocal lenses and minimally invasive glaucoma surgery. Over to John. I'll just play his video.
Thanks so much for introducing me. Dr. Pate, I'm glad you mentioned the training aspect of this. Myself, I'm recently just finished training last year, and I can say that these cases are the most coveted cases amongst the residency program. I think this is a really exciting time for SICS training in the U.S. Across the board, I think there's increasing excitement amongst residents to learn how to do this procedure. And amongst the faculty, we only have a few faculty here that are comfortable at least training it. And that number thankfully continues to grow. But I'm really excited to see how SICS training progresses in the U.S. over the next few years. So I really appreciate you inviting me to this discussion. I'm truly honored to be amongst such leaders in the field. Thank you. You can play the video.
Allow me to participate in this webinar. It's truly an honor to be able to share this platform with such leaders in the field. My name is John Anhalt. I'm one of the new attendings at Wilsey Hospital, and I recently finished a 1-year fellowship in academic global ophthalmology. As a relative newcomer to SICS, I found myself wondering how I could appropriately present a case to a community that was already so well versed and experienced in SICS. And what I'm hoping to do today is to present a challenging case that may open ourselves up to some discussion as to how SICS can be best utilized and which patients are most appropriate for surgeons who are primarily phaco-trained, such as myself. The case I'll be presenting is an interesting case of a 58-year-old male with a history of Axenfeld-Rieger syndrome. He was monocular from congenital glaucoma and had undergone goniotomy and trabeculectomy at a young age. As you can see from the external photograph, the patient had sequelae of congenital glaucoma with a ophthalmic eye, white to white of 14 millimeters, Hobbs striae, and a very temporally displaced pupil out of the visual axis with a underlying 4+ brunescent, very dense cataract. Visual acuity was hand motion in the operative eye, and eye wall master, consistent with the history of ophthalmos, revealed a very long axial length of over 30 millimeters. A couple points for consideration in the surgical approach towards this patient, mainly in regards to phacoemulsification versus SICS. Phacoemulsification has the advantages of being the most familiar, at least to myself. However, with the history of anterior segmentus genesis and the hyperdense cataract, increased phaco time in the eye may lead to corneal decompensation. On the other hand, SICS does pose some unique challenges in regards to this patient, especially set with a ophthalmic eye, large white to white, and long axial length. One can assume that the sclera may be very thin, which can pose some challenges for the tunnel creation. And as far as the wound placement, temporal versus superior, considerations that were at play were the potential for a future bleb procedure, so the decision was to operate temporally. And then finally, how to manage the pupil to provide a clear visual access. Like I had mentioned, decision was to operate temporally, both for astigmatic correction and to preserve the superior conjunctiva for potential need for a bleb in the future. The scleral tunnel proceeded without complication. After creation of the scleral tunnel, 2 paracenteses were made, and the anterior chamber was filled with viscoelastic. The anterior chamber is then entered with a 2.4 millimeter carrot cell, and 3 sphincterotomies were performed. The pupil was then dilated using iris hooks to better visualize the cataract. Trypan blue is then stained underneath the viscoelastic, which is then squeegeed out with additional viscoelastic. A large continuous curvilinear capsulorhexis was performed with microretradas through the main wound, and hydrodissection to gently hydrodissect and prolapse the nucleus into the anterior chamber. Viscoelastic placed underneath the lens, and the lens was successfully dialed into the anterior chamber. Nucleus was delivered using an irrigating vectus, and cortical cleanup was performed using bimanual irrigation and aspiration from the Centurion machine. Again, the anterior chamber and capsular bag were filled with viscoelastic, and a 3-piece lens was placed into the capsule. After placement of the 3-piece lens, the iris hooks were removed, and the pupil was reapproximated using MST forceps. After approximation of the new surgical pupil, a pupiloplasty was performed using a tenoproline on a CIF4 needle, which was sutured into place to recreate the pupil in the visual axis. And a second pass was performed more peripherally, going through the main wound. Viscoelastic was removed from the anterior chamber with bimanual irrigation aspiration, and the conjunctiva was closed. Following the case, the pupil was noted to be approximately in the visual axis, and the patient had noted marked improvement in the quality of his vision. Thank you very much for allowing me to present this case, and special thanks to Dr. Brenton Finkley, who was instrumental in his assistance. Thank you.
So I appreciate your patience watching through all the steps in the video, and I know everybody's more than familiar with all the steps of SICS. But what I was really hoping to do is kind of open it up to any discussion, especially these patients that come in with anterior segment dysgenesis. If there's any other considerations that you would take into account when planning for either SICS versus phaco. And I'll leave it to the panel or to any other questions out there.
Sure, that was definitely a very beautiful surgery. And I'd like to know if Dr. Ansari has some comments on it.
Sure, yeah, it's an incredible case, and I think one of the challenges with anterior segment dysgenesis is you don't really know what the eye anatomically is going to look like. And so that's why I believe SICS here is a preferred technique in the sense that you have a little bit more flexibility of what you can do in the anterior segment. But just really a beautiful case, John. And I think also one of the major things that you hit on was corneal endothelial failure. And we know that with prolonged operative times that could be an issue. And by utilizing SICS in this case, I think that you've sort of mitigated that risk. So fantastic job.
I have one question. I think Dr. Deepak Negur can answer that. I think it's a fantastic job done by Dr. John. What about this? I've seen a few of the Indian surgeons doing 2-throw, 3-throw, and 4-throw pupilloplasties. What kind of pupilloplasty would you have preferred in these cases?
I think it doesn't matter. I think the objective is to just ensure that the pupil comes to as small as possible, and whatever technique suits you would do the job. I think he did a fantastic job. I think I wouldn't change anything what he has done actually. Choosing the temporal side to preserve the superior conjunctiva was a great thought, and using the iris hooks. Many surgeons are a little bit skeptical on using the iris hooks in SICS. I think it is mandatory. It really helps you to see well, and that was a great job done. Congratulations.
Yes, Dr. Pamela.
Yes, I I would also like to congratulate Dr. John, and I think a very important point he made is that he actually combined the two great things about having manual surgery and phaco surgery. I mean, he used the hooks, but he also used the irrigation aspiration pieces from the Centurion, which actually helped him to leave a really clean and nice bag and put the Tripis IOL in the bag. So I think that should be the mind. I mean, we don't have to stick to manual and everything manual or to phaco and everything phaco. We can combine both and have an excellent result as he did. Thank you.
I think that kind of touches on what Dr. Petty had mentioned, using your best pitch or your best bowl. And at that point, it felt needless to turn a success into a failure using a technique that I'm a little bit less comfortable with.
Thank you, sir, for discussion.
I think Dr. Susan had just messaged that want to have a comment. Sorry, I think it was for the previous speaker or the speaker. We missed it. You want to say anything, Dr. Susan, before we go with the next speaker?
I do want to say something. I think my comments were when Jeff was talking about which is our best ball. And I think we all need to be conscientious of the fact that we have also been influenced by industry in a huge way. Cataract surgery is a very lucrative industry, and we need to pay attention, and that's why this society is so incredibly honorable and ethical, that we need to really pay attention to the fact that we can be swayed towards bimanual small incision cataract surgery or high pressure cataract surgery. And a lot of the time we have to ask ourselves, is the science supporting the technology, or is this a change in technology like femtosecond cataract surgery? Is that a choice that we're making because it's best for the patient, or is it a choice that we're making because of the peer pressure that's being created by industry?
Great. Thank you very much. I think, Jagdish, we can go ahead with the introduction of the next speaker. Before that, I would like to say a few words that here there's one junior who is also attending the webinar. He is none other than Junior Jeff Petty, and he is listening to this webinar. I think Sao sir and Boramani sir will be very excited that he started learning SICS right from this age, sir.
Yeah.
Thank you, Jeff, for making your son also join this webinar. It's really nice to see him as well. Okay, go ahead, Dr. Jagdish.
Welcome, Dr. Hagi. Dr. Hagi is the head of cornea and anterior segment surgery at the Wolfson Medical Center. He's the teaching associate with rank senior lecturer at the Tel Aviv University in Israel, and he participates in a lot of humanitarian missions worldwide. I'm going to share this video.
Hello, I'm Chagai Vizemer from Israel, and thank you for the opportunity to share our experience using the flange technique for IOL fixation. Dislocation of the intraocular lens, early or late, is a dramatic complication after cataract surgery. Although not very common, its rate has been reported up to 4% of cases. Actually, dislocated IOLs is one of the more common indications for surgery at our institution. One of the controversial issues is whether to exchange or fixate a dislocated IOL. There are different approaches to fixate a lens, most of them scleral fixation techniques. In the last couple of years, Sergio Canabrava popularized the flange technique using low-temp cautery to a 5-0 prolink suture to create a small mushroom that lies outside the sclera and under the conjunctiva. I want to share some cases done during the last year using the flange technique for several indications, using a 6-0 prolink suture instead of a 5. So let's start with the basic technique for fixating a looped haptic IOL, which is the ideal IOL for this technique. After marking the sclerotomy entrance points, the 6-0 prolink suture is inserted into the lumen of a 27 gauge needle and exits the eye. A second pass of the needle is above the haptic And this way we get a loop around the haptic. The same is done for the opposite haptic. We make a flange using low-temp cautery for each of the opposite loops and adjusting the tension of the sutures. We center the IOL, and once we're satisfied with the centration of the IOL, we finish the operation by cautering the two remaining flanges. This is an example of how these eyes typically look like after the operation with the small flanges under the conjunctiva. Plate haptic silicone IOLs are considered bad candidates for scleral fixation because of cheese wiring of the haptic, as can be seen in the picture back when we used tenoproline suture for fixation. So when I saw another case, I was a bit reluctant. But by using a thick suture such as the 6-0 proline suture, you can get a very, very stable loop for each haptic. And as you can see in the picture done one day post-op, the IOL is very well centered, and you can see the belt loop in the fenestration hole of the haptic. In this case of mild corneal decompensation, we replaced an artisan claw lens with a PMMA IOL using Calabrava's original technique. Notice that the ProLens sutures are pre-placed into the needle in advance, so the suture is pulled out of the eye. Once inserted, the IOL is very stable in the posterior chamber, and all you need is just to center the IOL and make the small flanges. Another PMMA IOL is this rare IOL designed by Fyodorov back in the 1980s. This IOL has been already scleral fixated 4 years before, but one of the sutures broke. You can see how easy it is to use the hole inside the haptic to pass the proline suture, this time in a radial configuration belt, and how beautifully the lens is centered at the end of the case. We have fixated different designs, different materials of IOLs, and even old PMMA lenses that had positioning holes in the optic itself could be fixated in an easy pattern. We can also use the flange technique to secure capsule fixation devices such as the ASIA anchor, in this case of a severe phacodonesis. We use one suture for each anchor with a very well centered IOL at the end of surgery. So as you saw in the presentation, by using this technique, we can fixate almost all kinds of IOLs, especially those with looped haptics and positioning holes, as well as capsule fixating devices. It is minimally invasive, and the learning curve for experienced surgeons is relatively short. It revolutionized our approach and became our go-to technique for IOL bag complex dislocations. I thank you very much for inviting me to this webinar, and thank you for your kind attention.
Thank you so much, Dr. Hege. It looked like you made still fixated so easy that it's more simpler than any cataract surgery. I think I'll start sending you cases from India to Israel. It's a fantastic surgery. A few quick questions, Dr. Hege. So what board needle do you use? Is it a 30 gauge needle, the thin board, or the wide board needle you use to dock it?
Okay, so we used in the beginning we used a 27 gauge needle, but now we are using a 30 gauge needle, which is not a thin wall, and the 6-0 proline suture enters excellently to this kind of needle, and no need for the thin wall, the 30 gauge needle.
And what about we do the same thing, the Yamane's technique as well, right? We bring out the haptics and try to flange it. So there are certain disadvantages that we don't know the long-term aspects of it, the conjunctival erosion. If it's open, then the chance of endophthalmitis also increases. So in your experience, what about the conjunctiva? It stays well, or do you tuck it inside the sclera a little bit?
Okay, so it's really a matter of how big the flange is made. Once you make it a small flange, I think it's more tucked into the sclera itself as the original technique by Amane, but we don't really know. We are doing it like less than 18 months, so we really don't know the long-term complications of such a flange on the sclera.
I think I'll invite Dr. Chinmay Sahu, who is also a vitreoretinal surgeon. Dr. Chinmay, you want to say something about this fantastic technique he showed?
Wonderful surgeries, sir. It was wonderful watching them. I had a couple of comments. One was the stability of the IOL. When you place it, the loop through the haptic, the question was, do you get a stable IOL in place? Maybe through a single, loop in the haptic, it's okay. But if you have a foldable lens with a longer haptic, how do you stabilize it? Number one. Number two, how do you take care of the top? Like sometimes you have situations where there's a twisting of the lens that occurs, and you see a lot of post-operative astigmatism in these patients. Third was when you are kind of using the cautery to make the tip bulbous, that it doesn't kind of dislocate into the subconjunctival space. You said you have an 18-month follow-up, but would that still be a viable option with long-term degradation of the material? These were certain questions that were coming to the mind, when I was observing that technique. Because what we'll end up doing is we create the scleral pockets and we take a 10-0 prolene and we loop it around and we kind of suture it and put it in the subscleral space so that, it's not exposed and the stability also kind of remains over a period of time. So I just had these questions. Otherwise, beautiful technique, amazing execution of whatever, and it's inspiring. Maybe we could try this later in our own cases.
The 6-0 prolene suture is much thicker than the 10-0. It's almost the area of the suture is 12 times larger than the 10-0 prolene suture, and the 10-0 prolene suture breaks. As you saw in one of the operations, it was just broke. So we think that the 10-0 prolene suture is a too thin suture for such fixation, and actually the 6-0 prolene, because it's a thick suture, is like a sustainer. You don't need to straighten the suture that much in order for the IOL to be very, very stable at the eye with no tilt and beautifully centrated.
All right. Great. Wonderful. I have another question from Dr. Nito. Dr. Nito? Yeah.
Yes, congratulations, Dr. Abizemer, for the wonderful presentation and technique. I would like to comment just to address what Dr. Joshi said about conjunctival erosion. It is very important in flange techniques to ensure that you do not touch the suture with the cautery. It's important to ensure that you have a very flat top and flange so that it stays clean at the sclera, and if you do not bury too much the suture, it won't be a problem because it's very smooth over the conjunctiva. So do not touch the suture with the cautery. That's a very important tip.
Great. Anybody has a question? Okay, one quick question, Dr. Hege, before we move on to Dr. Nito. For the beginners, what would you give your quick tips for the beginners to start? And do you have any experience with the Gore-Tex sutures? If yes, then how do you compare with the Gore-Tex versus these flange techniques using 6-0 prolene?
Okay, I haven't used the Gore-Tex suture because of problems in the hospital, but there are also problems with the Gore-Tex suture, especially erosion of the knot. If it's not buried into the sclera or into the eye, so it erodes the sclera, and it could. I think there is even a case of endophthalmitis because of not exposure in Gore-Tex suture, so we don't use it. Up till now, we didn't have any complications apart from exposure of the prolene suture itself that we had to shorten it. Apart from that, no complications.
Great. Thank you very much. And Dr. Susan has messaged. Dr. Susan, you want to say something on the Gore-Tex?
Oh, I just wanted to say it's I've used Gore-Tex several times, and it's difficult to use. It's difficult to tie. So if someone is trying this technology for the first couple of cases, it is not the time to learn how to use Gore-Tex, suturing it.
Right. Thank you so much. And let the pandemic settle down, Dr. Hege. I'll start sending you my cases to Israel. Thank you very much for that presentation. Yes.
Thank you. Welcome, Dr. Nito. Dr. Nito is from Brazil, and he's associated as a cataract surgeon with the public health system for the past 21 years. I'll be going ahead and sharing his video.
Hailo Mitron, Media Mantran Keli Dr. Amuli Sahu Kodnyevadena Jahuga. Mei staranke pratisti se yogyuan nordoston ke bincheia haraine keli samanit hun. I believe in better surgery. I think ocular surgery must constantly evolve in the direction of simplification, efficiency, and efficacy. What is the nucleus spin? It's a fast and repetitive nucleus rotation, hence the spin, in both clockwise and counterclockwise direction. Performed after hydrodissection, its purpose is cortex release. But why cortex release? Why is it important? Cortex management is an essential step, as all cortex must be removed during surgery. It is a time-consuming step. Cortex removal can present difficulties related to remnant location or visualization. Most importantly, it has been shown that most posterior capsule rents happen during cortex management. It is clear then that it would be extremely beneficial to facilitate or eliminate this step. Two maneuvers can help. One is the well-known and universally used cortical cleaving hydrodissection, but it often is not enough to achieve that. In conjunction with the spin, complete cortex release is achieved in the vast majority of cases. The spin technique is simple. It should be performed right after hydrodissection, with or without hydrodelineation, under irrigation with the phaco probe, or under OVD, using an instrument like the chopper itself or a Sinski hook. Multiple rotations are performed, first in one direction and then in the other. Usually 5 rotations in each direction is sufficient. Around 10 ensures complete cortex release in almost all cases. The spin is very easy to learn and to perform. No special instrument is needed, and it is easily incorporated in the surgical routine. It is a fast maneuver which saves a lot of surgical time when complete cortex release is achieved. As the forces are applied in a tangential manner to the entire zonular apparatus simultaneously, it is very zonular friendly. Cortex release and expulsion provides free space in the capsular bag, useful in nucleus management. When properly performed, it completely eliminates the cortex management step, saving time and providing safety. It would be logical to speculate that the maneuver friction removes lens epithelial cells, potentially diminishing the posterior capsular opacification rate. Let's see some spin examples. As you can see, clockwise rotations and then counterclockwise ones. The farther away from the center you push the nucleus, more grabbing power and control you have, but always respecting the rhexis margin. Gentle back and forth movements can be employed until nucleus is free. Then, nucleus rotations follow, 10 in each direction in this case. Nucleus management is done with the surgeon's preferred technique, and most of the times, after nucleus management, no cortex is still present. It is a very useful technique to master and incorporate in your surgical routine.
Very, very interesting, very surprising, I think I can see everybody laughing here. Well done, Dr. Nito, but how about in the hard cataracts? I just had a quick question. And it looked like everything is coming by itself, and it looked like the cataract wants to come into your phacoprobe.
Well, in hard cataracts, usually there is not much cortex available or present. So the maneuver itself is comparably easier than when doing with softer nucleus. So you proceed the same way. It's very important to notice that this is not the simple initial nucleus rotation that one performs every time you do a phaco surgery to release nucleus. It is different, and many may be concerned about zonular integrity of the maneuver. In fact, almost everyone is kind of accustomed with the greater friction that exists in the beginning of the movement. After nucleus is free and some cortex is released, it's surprisingly how the nucleus can rotate without much friction, and one can gauge the amount of the number of rotations needed by how much friction you're having. When you're having almost no friction, it is a sign that almost all cortex was released. I thought it was very interesting to bring this technique to this meeting because I use it in phaco. I'm mostly a phaco surgeon, but I perform SICS as well. But it can be used in the same way in SICS surgery, just under OBD. You don't need to do it under irrigation. So it's a technique that can be used by all manual cataract surgeons. So I thought it was interesting to bring it here.
Dr. Boromani sir, your comments, please.
Yeah, it was excellent video, Dr. Nito. I have been doing this technique for last 7 to 10 years. I am mostly SICS surgeon. I will not call it as a spin because I do at least minimum, even if the nucleus is free, I do minimum 5 rotations clockwise and 5 rotations anti-clockwise because you are doing the rotation through one port. The clockwise rotation will take care of half circle of the circumference of the capsular bag. So if you do it anti-clockwise, the pressure is exerted on the another half. So this way you can clear the cortex. Second advantage is that it acts as a capsular polisher also. The nucleus itself polishes the posterior capsule also. And after this, once the nucleus is out, many times I do the water jetting with a small cannula through a side port. So that flush of water also many times loosens the cortex. But I'll call it as a nuclear rotation because I do it with a gentle speed. The way you are doing is literally looks very dangerous, and it is a literal spinning of the nucleus. So it repairs a strong zonule as well as strong surgeon's heart.
Neto, you have done a wonderful thing, and you have stressed a point which all of us should emulate it. Because this is the way you have stressed this point is very important. We all do it, but sometimes we just feel that one circle, 2 circles, leave it. But you dramatized it, and it is really going to be remembered by everybody. It's a wonderful contribution. Thanks to you.
Thank you.
My friend Boramani is also doing it, but he has not popularized it. But you are popularizing it. I must thank you.
Thank you, Dr. Nito. Anybody has any quick comments before we move on to Dr. Deepak Meghul? Okay, I think Dr. Nito, it makes me remember great spin bowlers we had in Indian cricket. There's the Shane Warne, the Muthaiya Muralitharan, and the Paul Adams. The kind of spin you are doing in the cataract surgery, you're you are no less than a cricketer, because India is a great fans of cricket. I don't know how much you follow about cricket, but definitely it's a fantastic presentation. I must really thank you for that. Yes, Dr. Deepak, you have a quick comment.
Thank you. I think Dr. Nito's surgery list is very long. I think, you know what, every innovation, there is a necessity for innovation to come. He is such a fast surgeon, and he doesn't want to waste time a little bit to introduce another set of instruments. And that's the reason why he has this innovation has come into play. And it's very successful for him, and it really works well. And congratulations and hats off to him. It really is wonderful technique. Thank you for sharing it, Nito.
Not to forget the excellent Hindi which he spoke at the beginning.
Very well. Wonderful. Thank you for that as well. Thank you, Dr. Nito. Next, we'll go ahead with another spin bowler, but he doesn't do spin in cataract surgery, but definitely his videos are mind-boggling. And he's none other than Dr. Deepak Megur. He's the director of Megur Eye Center in Bidar in Karnataka. And I must tell you that he has won several awards. And he's a fantastic cataract and phaco and refractive surgeon. It's really a treat to watch his surgeries. I will not emphasize much. I think you will just see his surgeries and enjoy. Go ahead with the Deepak, sir.
Hi friends, this is Dr. Deepak Megur, and I'll be speaking on tackling the unique challenges we face during manual SICS while dealing with eyes with loose zonules, especially in eyes with fluid exfoliation. In such eyes, the most common difficulty or complication that happens is during the mobilization of the nucleus out of the bag. If you're not careful, more often than not, we may end up in having an inadvertent intercapsular extraction, as the capsular bag, which is invariably sticking out of the nucleus, just comes along with the nucleus owing to the loose zonules. So here are my top 5 pearls to deal with such situations. Tip number 1, make a bigger excess. A minimum of 5.5 millimeter or more is critical. In certain situations where inadequate pupillary dilatation may prevent us from having an adequately sized rhexis, I would use hooks to expand the pupil into a bigger rhexis and perform a secondary larger rhexis if required. So tip number 1 is to see well. Number 2, good hydrodissection. This is probably the most critical step. It ensures that the nucleus is completely devoid of its capsular attachment. At this point, I can see the bag is still moving when I nudge the nucleus. I repeat it until I can see that the bag is totally free from the nucleus and it does not move when the nucleus is being rotated. Number 3, early insertion of CTR is critical in such situations. Most common error performed by surgeons is to delay the insertion of the CTR. Early insertion of CTR is a key. Creating some space under the capsule by using sodium hyaluronate eases the insertion process. I prefer the bimanual technique of insertion, wherein I compress and support the ring with my non-dominant hand to minimize the stress on the zonules while I insert the ring into the bag. Now coming on to the most crucial step, that is nucleus prolapse. The most important trick in such eyes is to use the bimanual way of manipulating or wheeling the nucleus out of the bag. I support the equator of the nucleus with one dialer and the other dialer just wheels out the nucleus out of the bag. If you can master this technique, we can manipulate the nucleus out through the smaller rhexis as well, even in eyes with weak zonules. Lastly, inserting the lens. Well, one can put in the lens into the bag, but my personal preference is to use the IOL trap technique, wherein a hydrophobic multi-piece lens is placed focus with the optic being trapped behind the rhexis, which ensures better long-term stability in such eyes. Thank you for attention and the opportunity.
Thank you, Deepak sir. As wonderful as always. There's nothing new to describe about your presentations. It's always great. one technique, it's a good technique, I feel. I don't know how many of us actually do that, especially when you are holding the superior part of the iris with a dialer, trying to protect it rather than getting engaged while rotating the nucleus. I think it's one good tip which I think most of us have to really follow it to avoid accidental iris trauma, especially in these cases. Yes, Dr. Pamela and Dr. Zubair, you have any comments on this technique?
Yes, congratulations, Dr. Deepak. Great videos, and I really enjoyed the pearls. And just one thing, I saw you put the iris hooks. If you are doing a manual incision, even though if you're having, for example, a superior approach, do you put hooks in the superior part also, or do you just go far from your tunnel?
Usually I put 4, avoiding the tunnel area, but sometimes if you want to extend the rexus in the superior quadrant as well, we put in a hook from the tunnel itself, just to ensure that we are seeing that part and make the capsule opening, but release that hook and remove it out when you're trying to get the nucleus out. So that's going to obstruct your nucleus delivery. Use it temporarily. I use it temporarily when just to see the rexus part of it. And once the nucleus is into the antechamber, I release it and pull it out, and then the nucleus comes out. So you can use the one hook in the tunnel itself, but avoid it during nucleus extraction.
Thank you.
Yes,
that was a fantastic case, Dr. Deepak. Thank you so much for sharing your pearls. I think in the United States, we're oftentimes using SICS surgery for some of our more dense, complicated cataract procedures, and oftentimes those are the lenses that have either pseudo-exfoliation or zonulopathies. So I think the bimanual delivery of the prolapse of the lens was a really helpful technique that I took away from you. So thank you for sharing that.
Yes, Dr. Susan?
Fabulous presentation and great pearls. I'm learning a lot today. Can you just talk again about the placement of the capsular tension ring as early as possible? That can be a challenge and can really cause some stress on the zonules. I'd like to hear if you have any other pearls about that.
Yeah, I think most often than not, it's actually beneficial if you introduce the ring early. It's more of a phobia that we are going to traumatize the zonules for introducing. The trick here is to create some space between the anticapsule and the bulky nucleus. So if you don't have a cortex, I use sodium hyaluronate. It creates some space. It's a cohesive viscoelastic. It creates space, and that allows an easy insertion of the ring. And always I use a second instrument to compress upon the CTR, so that when you're trying to dial inside, it doesn't cause any stress on the rest of the bag. But I think providing an equatorial stretch to the bag before the nucleus is collapsed into the nucleus is the single most important critical step to prevent further damage to zonules. If you delay the CTR insertion, the bag is going to come out when you're trying to collapse the nucleus out. So that is the trick here.
Yeah, that's a good point. A very good point.
Dr. Chinmay, you have quick...
Dr. Srinivas, Dr. Megor, wonderful videos. I had just a couple of points here. Like whenever you're trying to mobilize the legs, the bimanual technique he showed is wonderful. There's another small point. If you find that the nucleus is getting trapped and it's not easily coming out of the bag, taking 2 minutes, putting some visco behind the pole which is kind of collapsed, deepening the anterior chamber, and then again restarting sometimes helps. Quite often trying to move in the opposite direction. If you've been going in a clockwise, trying to reverse the direction again can help in removing the nucleus out of the bag without creating complications. So that was one point I wanted to add. Second was for Dr. Susan, like when we deal with CTR rings, one trick that I have found useful is when you with one hand you are pushing in through the side port or through whatever area you're pushing the leading edge of the CTR into the bag. Once you have partly negotiated it into the bag, what I tend to do is I kind of engage, I take the other from maybe through the other side port, can ensure that the loop doesn't suddenly open up into the anterior chamber. That's where the problem occurs, where it suddenly snaps open and part of the loop, a CTR ring goes in the sulcus. So mechanically avoiding that and slowly, gently negotiating it into the bag, that helps apart from the other points that Dr. Megor mentioned as well. transferring a good amount of viscoelastic and other things. Those are a couple of points I thought I would like to share. Thank you.
Thank you, Dr. Chinmay. I think we'll move on with our next presenter. He needs absolutely no introduction at all, and he is none other than Dr. Amulya Sahu, sir.
Yeah, my video?
Yes, sir. Jagdish.
The marker is developed by me. It marks 2 millimeter on the steep axis, 1 millimeter behind the limbus. Conjunctiva and tenon are cut separately, leaving a frill of 1 millimeter conjunctiva to facilitate holding with the forceps. Vessels are erased with wet fill cautery. Frown incision is taken 2 millimeter, 1 millimeter behind limbus, 1.5 millimeter back cut is given on either side of the incision if the lens has to be implanted without injector. If lens has to be injected with injector, there is no back cut. 2 side ports are given on left and right side. Rhexis is done to stabilize Rhexis is done as a routine manner. Tunnel is extended into the substance of the cornea and moved sideways. Triplanar self-sealing incision is done to enter the AC. Lens is mobilized into the AC by nudging with my modified dialer. Lens is brought out with modified vectis broken at the tunnel. Remaining lens fragment pointed end is mobilized towards the tunnel and taken out. Cortex cleaning by 24 gauge Simcoe cannula. Lens polishing is done. Lens is inserted, mobilizing through the scleral pocket. Lens is dilated into the bag through the side pocket. Side pocket and wound are sealed, air bubble injected, and tenons and conjunctiva is cauterized.
We are absolutely speechless with the video, sir. So definitely, I would like to Dr. Boni Henderson to comment on it.
Sure, I think speechless pretty much sums up my reaction. That's amazing. I mean, 2 millimeters, it looks better than a phaco eye for sure. Faster, easier, less traumatic to the eye. So that's incredible. So thank you for continuing to progress this movement and make each procedure better and better. That's amazing.
By the way, Boni, I'm putting all the premier IOLs for the 2 millimeter. I've done so many multifocal toric IOL and so it is. I think all of you should start doing it, and we can improve with the passage of time. It will become totally bloodless. I'm focusing on that. If you are little watchful, we can do a very absolutely clean surgery and much more comparable, because most of the technosurgeons are extending their wound after that, because they are in a very stable, unstable platform cornea. We are in a stable platform sclera. So we can do a very precise incisions where the cornea people cannot. They have many a time they have to extend it, but they don't admit it, but they extend it.
Can you share with us the size of your irrigating vectus? Because I probably have a wider irrigating vectus than the one you're using.
No, this is modified, and because it has taken a long time to modify and find out what is working. So because there is an edge in the front, if you have a little light up, curve is there, so which engages the nucleus. Most of the time, our vectices don't have a round surface. If you are bringing out a lens with a round surface, you are going to rub the endothelium. But if you have a little bit of hanging edge in the front, that engages the nucleus and glides it out. So that is it is not a irrigating vectis. It is a simple vectis. I inject, when I'm dividing the nucleus, I'm not shown it here. Then the vectis visco cannula, the tip is pressed and it becomes a square. You don't use the round cannula because there is a possibility of descent separation. So when you are going for the side port, you just compress with your artery forceps the tip, so it becomes flat. So when you are using the flat, you keep that vectis behind the lens and go on injecting viscoelastic above the lens and compress it, and you can divide the nucleus to 3 and 4 pieces. Then you flush it out. So there are other videos where I've shown this, but the time constraint is there. Sometimes we will have a bigger show of this. So
truly, that's an exceptional one, sir. Truly, and Dr. Susain has actually a question for you.
First of all, I too, like Bonnie, am speechless. This is extraordinary. Congratulations. And you are a magician. And I'm honored to have met you. And I want to learn this from you. But my question is, I've tried to crack the nucleus in the incision, and it has not been successful, and I've had trouble with it. So I just would love to hear your words of wisdom on how to protect maybe I'm afraid that I'm going to hurt the endothelium, but I've never successfully done, I'm trying to make my incision smaller, and I end up enlarging it because I'm afraid I'm going to hurt the endothelium.
So see, endothelium, I have taken only for the endothelium study, we have taken a Conan specular microscope, so that I don't do something when I don't know what I'm doing. So that do not pay me anything, but except study purpose. So I am seeing that I could have shared there is a presentation there. Endothelial loss is very minimum in these cases, but we once you start doing, then the improvement will come. Then the fear quotient will go. Now that you have seen, I have done it, because I have done it 2005 3 millimeter a live demonstration. Last year I did in All India Institute a 2 millimeter incision, and next day vision was 6/9. So that shows the public exhibition of your skill assures you that you are in the right track. So it is the fear, because now you don't have that vectis and other things. As I told you, that the vectis which is available is not meant for this purpose. So they were for big incisions. For small incision, you have to hold the lens and glide it out. Unless you hold the lens, you are going to rub the endothelium. It is because what is the support? You don't have the support for the nucleus. So most of the problem are happening because of the vectis. The vectis was not designed for it.
Right.
And people like you who are enthusiastic and committed people, once you focus your mind, I think you will improve on this method. Okay. And interact. We can have some in Tanzania or anywhere we'll do it.
Yes. May I ask, how do we get the vectors, and why are you need to put your name on this technique? The Amula. I think it's really a contribution, and this is it can become a refractive procedure without the expense of phaco.
Yep.
Congratulations! Wow,
Thank you so much.
Yeah. Yes, Dr. Chinmay. Quick comments, please.
So I have seen my father do this, and I can tell you that in spite of doing thousands of phaco surgeries, when I see him do it and I try to do it in my own cases, I find it difficult. So it's quite a skillful thing that he's doing, not so easy to emulate. Few things that I've noticed is the typical vectors that is being used in most institutes is broader and doesn't have any serrations. He's kind of designed it in a way where the gauge, it's a little narrower so that the nucleus gets well supported on that, and he has serrations on the vectors, which again helps with better engagement of the nucleus on the vectors. Also, the way he cracks the nucleus, it looks scary because whenever I've tried, I've worried that I might damage the posterior capsule, or I might eventually land up rubbing the endothelium. I think the trick lies in a proper engagement of the nucleus and using the serrated visco cannula. So he has a cannula which has a little, I would say he's kind of given the tip a little knife-like edge, which helps in cutting through the nucleus. Narrower vectors, serrations on it, and the tip of the visco cannula being given a knife-like tip wherein you can cut through the nucleus and divide it into finely. It's still extremely difficult to learn and copy.
Thank you, Dr. Chinmay, for those quick comments. I think we'll move on to the next speaker. Before that, Boramani sir just mentioned 2 mm incision without the machine, and here I would like to say he's the machine by himself, so he doesn't need any machine. So we'll move ahead with the next speaker, Dr. Jagannath sir, Jagdish.
Welcome, Dr. Boramani sir. He's the executive chairman of the ISMSCS. He's a very down-to-earth, very approachable person, and nothing less to say. He's actually the other eye for the ISMSCS, like Dr. Abu Sahu. So welcome, sir, and then I'm going to share his presentation.
And he's also the first person to start SICS under topical in India.
The presentation is to show how the astigmatism can be tackled by customizing the scleral incisions. In case of superior straight incisions, the astigmatism can be progressively reduced by reducing the size of the incision. The induced astigmatism can be progressively reduced by making the incision more and more curved. Compared to superior incisions, the temporal incisions are weaker in neutralizing the astigmatism. Temporal curved incisions are astigmatically almost neutral. The effect of superior-nasal and superior-temporal incisions are in between the superior and temporal incisions. To get the good effect of the vector forces, the incision should be centered on the steep meridian. To minimize errors, I mark the horizontal and vertical meridian in patient's sitting position. Once the patient is on table, the steep meridian is marked on the cornea and the incision is centered on the steep meridian. Here are few pre-operative and post-operative corneal topographies. The post-operative topography is done approximately 20 days after surgery. The type of the incision is shown between the two topographies. Here, with a moderately curved incision, 0.39 diameters of astigmatism is reduced to 0.22 diameters. Here, the vertical meridian is steep. A 1.12 diameters of astigmatism is reduced to 0.15 diameters with a straight incision. A straight temporal incision significantly reduces astigmatism of 1.24 diameters. This is a case of multifocal IOL. The astigmatism is insignificant and is slightly reduced further. This is a case of high astigmatism of 3.3 diopters. The astigmatism was significantly reduced with a straight incision without using a toric IOL. This becomes a premium surgery without using a premium IOL. Now I use the term surgically corrected astigmatism instead of using the term surgically induced astigmatism. Let us call this as KICS, customized incision cataract surgery. With customized tunnel engineering, it is possible to wipe out or at least minimize the stigma of astigmatism. Thank you very much.
The kicks really had a kick on us. It was really, really nice. I would like to ask Dr. John to actually have any comments on it.
I think that's the way that he's able to mitigate some of that astigmatism with the customized incisions is excellent. I think it can push SICS from curing blindness to correcting astigmatism and optimizing people to having 20/20 excellent vision. So I think some of his points there they were very interesting in the use of the topography to guide his incisions.
We can definitely say it's a refractive surgery. So moving on, Dr. Nito, do you have any comments on it?
Well, I think it's wonderful and it's amazing the kind the controlling astigmatism the way we saw. And I think it's a wonderful technique because it is a very affordable, a very important improvement on the surgery. So congratulations, Dr. Baramani. Amazing. Just amazing.
Thank you, Dr. Nito. Can I comment?
Please, sir, please.
Yeah, if someone asks me what is your induced astigmatism, the question is very irrelevant to me because he should ask me how much astigmatism we can reduce. If the astigmatism is zero, if the cornea is spherical, you can have a perfectly U-shaped incision as Dr. Sahu has showed you. Even there is no need to go up to 2 mm. You can have the ends of the incision 4 mm, but a superior temporal or temporal U-shaped incision will not induce any astigmatism. I have done thousands of the cases. And secondly, only thing is you should be of nuclei because sometimes you have to manage through a small or tight incision, but you can have a good Peko fragmentation technique. I got my own technique of endo-expression of the nucleus, but which I was not able to show in a 3 minutes video. But this way you can have a wonderful control on the astigmatism. I operated many doctor patients who wanted multifocal IOL. The astigmatism was about 1.52 or sometimes 2.25, but without a toric multifocal IOL, so I just put multifocal IOL, and the astigmatism has been taken care by scleral incision. So this is the beauty of the scleral incisions because you can customize the incision. You cannot have always a one fixed 2.2 mm corneal incision for all types of astigmatism the patient is presenting with. So on the contrary, you can mark the meridian using all the markers, steep meridian, and then fashion your incision around that steep meridian. So depending upon the pre-existing astigmatism, you can have the shape and the length of the incision. Now there can be individual variations in your technique and your methodology of inducing the astigmatism. So all your one type of incisions you can put in the softwares available on the net to calculate the SIA, and you can find out your own SIA of different types of incision and in different meridians and can formulate your own algorithms. But this works wonderful because the scleral incisions are more stable, they are more steady, and surprises are less as far as the astigmatism is concerned compared to the corneal incisions, because cornea is very close to the optical axis. Even if there is some heating of the cornea or some raggedness, you can get surprise astigmatism, which is comparatively less in scleral incisions. Thank you.
Dr. Hege, you need to have any comments or?
Yes, I'd like to ask Dr. Baramani.
Yes.
How do you manage unfavorable angle, like supranasal in the right eye, for example,
Yes.
40
Yes.
degrees?
Yes. Now see, actually all these are there in my presentation, but in 3 minutes video, I couldn't accommodate everything because you have to sit on the steep meridian. Now for right eye, you can always, whatever may be the incision, you always get say 20 degrees to 200 degrees to operate. So leave apart the extreme nasal area, but if it is 20 degrees also, you can have the incision on that. And you can go inferotemporally also. If it is 20 to 30 degrees below the horizontal, below 180 meridian, you can sit inferotemporally. If you are right-handed surgeon, there is no much difficulty on going inferotemporally, but in the right eye. But if you are a right-handed surgeon, going inferotemporally in a left eye becomes more difficult. But sometimes I have taken superior-nasal incisions also. That is not a problem. Like say if the meridian is 160, there is a case doctor-patient where the steep meridian is 165. So I have taken the incision superior-nasally in the left eye and on the steep axis of 165. So that is not very difficult operating from the nasal side also. I am thinking of using medial rectus traction suture in some cases, but so far I have not used it. But without any traction suture, we can operate. Superior nasal also you can operate. If it is extreme nasal, it is not required because then you can go temporally or slightly inferotemporally.
Thank you, Boramani sir, for that excellent presentation and the beautiful techniques you showed to make it more and more machineless. And you showed the Boramani machine doing the surgery. Now, we move on to the next speaker. He is another doyen in the field of ophthalmology, postgraduated from All India Institute of Medical Sciences. He is also the medical director of the chairman and the medical director of Haptic Netralaya, very innovative. And he is another machineless person, and the name of the machine he uses is the Ravindra machine. So, can we go ahead with your presentation, sir?
Sure. It's my privilege to be here as a part of it. Should I play the video or?
Yeah, you want to play it, sir? Or you want me to play from my end? So do you want me to play from my end or your side, sir?
You can play it. I would like to give the voice.
Oh, okay, sir.
Yeah, this is a case which is really challenging. Patient had 3-port vitrectomy done a couple of months ago, and the patient has a posterior subcapsular cataract. And then I know that zonules are going to be weak. I know this patient has an IFIS. People doesn't dilate whatever you do beyond this. I've made a direct incision in the temporal quadrant, little on upper side, with a 2.8 millimeter. It's a little longer, and the start of the entry is through the conjunctiva. It's gone through the sclera, gone through the entire limbus, and gone through the cornea. I filled the anterior chamber with viscoelastic, and the cystitome enters the anterior chamber through the floor of the tunnel at the limbus. So the cystitome, as you can see here, is in the anterior chamber through a pinpoint entry, which is done with the tip of the cystitome, and through that I've filled the HPMC, hydroxypropyl methyl cellulose, because it's a pinpoint entry through the floor of it. There is no leak of viscoelastic, and the AC remains deep. The tunnel is enlarged. You see a fill of conjunctiva there, which immediately seals it during the post-operative period. That is a lignocaine, which is I'm putting it on the surface of this, and I've done a capsular separating hydrodissection. You can see the iris is tumulus, so you can see that how it is. What I'm going to do is I'll rotate the nucleus and epinucleus within the capsular bag. I'm not a neato to rotate it so many times, but half or 3/4 of rotation is enough, and it comes through by manual rotation into the anterior chamber. It's bisected in the anterior chamber. I'm continuously injecting viscoelastic in front of the nucleus. Nucleus glides out of the eye because of little positive pressure. Entire surgery is done without any positive pressure. It's in normal pressure. I'm very careful. Fluidics is very low. The input of fluid as well as the aspiration is under my control. I know the silicone oil can peep in if it's too hypotonous in the anterior chamber, or the fluid can go back into the vitreous cavity. If I'm pressurizing it, I'll have to balance the inflow and outflow, very minutely with my own control. I don't have a machine. I don't have fluid going without any purpose or aim into the anterior chamber. It's very controlled inflow and outflow. Little bit of pressure, the leftover cortex material comes out. The can see the silicone oil behind that. It's trying to come out, but then I'm trying to hold it. The surges are not to happen. There is no side port. There is a single port. Through the Simcoe aspiration irrigation cannula, which is under my control, I'm aspirating the cortex bit by bit, and pupil has narrowed down, but I'm certain that I'm going to remove every bit of cortex. I'm injecting visco again, just an amount that is needed, so I don't want to pressurize it. Dip the lens in the visco, fold it, and I don't use an injector. I need to be very, very steady and slow when I'm doing it. I use a probe. That's a probe. I hold the cartridge in my left hand. The probe is there. AC is not very deep. It's just enough. And the probe pushes it. The cartridge is slit on the top so that there is no resistance for the lens to go inside the eye. I know it's in the bag. And I'm going to inflate a little bit of visco in front to deepen the chamber. I'm very careful at this moment. And I'll rotate the lens into the capsular bag. And at the end of it, I'm going to remove the viscoelastic in the capsular bag behind the lens, and the patient is, will be attended by a vitreoretinal surgeon for the removal of the silicone oil in the same sitting. The beauty of this tunnel is it's not stretched at all at any point of time. The phaco, when I use it, it burns the tunnel. It doesn't happen. There's no need to suture the wound, and the conjunctiva heals very quickly during the post-operative period. Normally, there's no need to bandage this eye, and the astigmatism it produces can be anywhere from 0 to 0.75 depending upon where I've started the tunnel. So I form the chamber, and that's the end of my surgery for this particular patient. Thank you.
Wonderful surgery.
Thank you, Ravindra sir.
Thank you.
Beautiful. As always, I think the crystal clear quality of your video recording and the way you take the incisions and everything are really, it's love. Everybody would love to watch your surgeries. Any quick comments? Does any of the speakers? Yes, Meghur sir, please go ahead.
I think what Dr. Ravindra sir, I think is a totally new concept. One of the drawbacks which we were always considering that you need to dissect out the conjunctiva. I think basically challenging that notion by introducing a translimbal tunnel, and he's just questioning that whole concept that you're going to disturb the conjunctiva. I think it's one of the great modern innovations. I'd like to congratulate him, and I'd like just to know from him the stability of this wound when you compare to a traditional scleral tunnel. I think this is really a way forward to this, because one of the common points against Ismsics debated was you're going to disturb the conch. And here he's shown an elegant technique where he's not making a conjunctival peritomy, but he's creating a tunnel through which a nucleus is fractured and brought out. Sir.
Thanks, Dr. Deepak. I always had a dream that Ismsics should be as simple, as straightforward, as elegant to look at, and as clean as phacoemulsification surgery. When you do phaco, it looks so nice at the end of the surgery. Everything is neat and clean. Can't we do it in Ismsics? This is a question. It was a challenge to transfer myself from the traditional sclerocorneal tunnel to the. This is a bit scleral, so it's not entirely corneal. I'm going through the sclera, I'm going through the entire limbus, I'm coming up to the cornea, and my problem was to keep the incision straight. It used to go like that or go like this to begin with. It's a journey which took me 6 months to master. I won't say master, to be comfortable with it. And the trick is, it's a 4-plane incision. Initially, let's go down on the conjunctiva, get into the sclera, and then go up on the lamella of the cornea, then go down to enter. Again, to keep the incision straight on the corneal side, you have to go up towards the dome. It's a 4-plane incision. Then you can have, I learned this technique in a difficult way, but now, I always feel, why didn't I do it 10 years ago, 15 years ago? There was always a phobia that an entry taken with a sharp knife can be as elegant as the tunnels that we create with the crescents. So it's It's possible to do it. I've learned and I'm very happy about it.
Great. Definitely looked very elegant, sir. More elegant than a fake for sure. And Dr. Jeff, you have a question?
Just a general comment for everyone. One of the really beautiful things is coming and seeing how we can advance this surgery. As you can imagine, it's just like anything else. If you're able to do hundreds of these over a period of time, you're really going to be able to innovate and find beautiful ways of doing the surgery. For anyone doing a surgery, just perhaps even just 100 times in a year, it's much more difficult to do so. So I just want to congratulate all of you for the advances. I mean, my mind is just totally blown by what I'm seeing and what you're doing. Thank you, everyone.
Before we go into the next speaker, Dr. Boni, do you have any comments on it?
I agree. I mean, it's one of the nice side effects of COVID is that we're actually able to participate in these types of webinars from our colleagues from around the world so much more easily than having to get on a plane and fly all the way there, jet lagged and all the rest. Although it's not as much fun because I don't get to see you personally, it's really wonderful to be able to share this. And again, thank you for educating all of us. And I echo Jeff's comments that it really, as they say, it takes a village to kind of progress ophthalmology forward. And it's wonderful to hear all these great innovations coming from your wonderful colleagues in your country. Thank you.
Thank you. Thank you. Thanks a lot, Dr. Ravindra, sir.
Can I just add one comment here?
Please, sir. Please, sir.
The one thing that I would like to stress upon in these techniques is the amount of fluid that goes to the eye is only about 30 to 50 ml. 30 milliliters is the normal amount of fluid that you need to complete the surgery, and the max that runs through the eye is 50 ml. And endothelium is highly protected in this technique because we do both emulsification and these kinds of techniques, and we analyze endothelial count before and after. Many times there is no endothelial loss at all, zero endothelial loss when you have nicely protected it. And the highest thing that I would like to add on here, the most beautiful thing is the amount of control you can do with your own fingers. I infuse fluid with the silicone bulb and aspirate with left hand a 5 ml, Lurlock 5 ml syringe, and the control is beautiful. The amount of control you have in the anterior chamber, push the iris diaphragm back or to shallow it whenever you want. That's the most critical thing, and that can be very well balanced in manual techniques. This is the 2 points that I would like to add on to the discussions.
Oh, great, sir. Thank you, sir. Thank you. That was really nice. And we invite the next speaker, Dr. Rajiv Rao, who is the international coordinator for ISMSICS. And he is actually well known.
Sorry to interrupt you. There's a small change. Now we are going with Dr. Suhas Hadipurkar. And then we will have Dr. Rajiv Rawat. So to introduce Dr. Suhas Hadipurkar, sir, one of the most respectful, down-to-earth, unpresumingly one of the great cataract surgeons that our country has witnessed is none other than Dr. Suhas Hadipurkar, sir. So we would love to see your presentation, Dr. Suhas, sir. Please go ahead.
So much. Thank you. This meeting so far has been really, really wonderful. Some amazing pictures. I think Dr. Reddy going to share my thing? Or,
yes, sir. Yes, sir.
Every piece that we saw was very fantastic. MS Ravindra, it was really good. Even Amulya, you showed very impressive. You've been always talking about it today. I saw it for the first time. It was very, very impressive. Mine would be a little different, but I'm just talking about iridodialysis repair.
Sir, can you be just a little louder, sir?
No, but I think it is a disinsertion of the iris from the scleral spur. It commonly occurs secondary to blunt ocular trauma and sometimes even after intraocular surgical procedures as a lesser known complication. Large symptomatic iridodialysis often needs repair. When it is temporally located, iridodialysis will have symptoms like diplopia, glare, and photophobia. Cosmetic issues such as polychoria and ectopic pupil might occur due to large defects. Hyphema, angle recession, glaucoma at times, hypotony may also be found. The advantages of this technique are that anterior chamber remains stable throughout. Multiple sutures can be passed without withdrawing the needle from the chamber, and large dialysis can be repaired easily, and it's a sleek procedure for a large defect. This is a case which I call as making of a pupil. A case of 300-degree iridodialysis came for a repair. On close examination, the entire iris tissue was bundled up in the wound. The tissue was devitalized and difficult to approximate. The sewing machine technique, as described by Dr. Ravi Kumar, was attempted in this case. Tenoprolene suture was threaded into a 26 number needle and used to stitch back the outer border of the iris tissue to where it tore from. Using microforceps to hold the tissue in place, the threaded needle is passed through the iris tissue and brought out through the groove at the limbus. Once the loops are created, they are cut and tied with adjacent sutures, and the knots are buried in the groove. Because of unhealthy nature of the tissue, the handling had to be delicate enough to achieve the circularity of the pupil. But the end result was cosmetically and functionally acceptable. Thank you.
You really brought life into that iris. It was amazing. So I would like to, Dr. Boni actually has something to add on it.
Sure. I think those types of techniques, even though it's not very common that we have to do them all the time, it's really nice to be able to watch how to do these. And when they fall in your lap, it's really nice to be able to refer back to videos that are hopefully saved on the Ismsics website so that we can look back on them. And these are the types of changes that I think for a patient, it makes the biggest difference. So for, when they are post-op, of course they want to see well, but cosmetically makes a big difference. So it makes them from looking abnormal to looking normal. So thank you for your beautiful surgery.
Thank you. Dr. Boramani, you want to add something onto it?
No, it was a fantastic video. I don't know where it's an excellent
All right. Thank you. Thank you so much.
Suvas, you should have some courses on this for us.
Yeah.
They are not the case that come too often, but I have seen quite a few of them. Like, when you're doing vectors, when you use vectors, and especially for SMC, if you are not very careful, and if you catch the lower iris, you can easily tear it off. So, especially while doing SICS, you do come across such complications. When it tears and if you're not aware, almost more than half of the iris is torn from its root. Then managing it either primarily or as a secondary procedure, it's quite delicate problem.
Yeah, yesterday we had a Bangladesh webinar, and there also this point was raised. So I think it is time that you conduct some courses on this. So So for us to go and attend and do something, we have to learn. Thank you for sharing this.
Thank you, sir. Thank you, Dr. Suhas, sir. It was an amazing video. We'd like to move forward to Dr. Rajiv Rawat, who is the international coordinator for the ISMSICS. He actually is well known in India for his smart SICS. He's really smart about it, and then you have to, he holds a patent for it. And Dr. Joshi, sir, would like to add some more points probably on him.
Who said that SICS is a poor man's surgery? I would like to call Dr. Rajiv Rawat as the Bill Gates of ISMSICS in India. And here comes our Bill Gates, Dr. Rajiv. Go ahead, sir, please.
When he is coming, let me tell him that he charges the highest amount for this cataract surgery, 2 lakhs. So he has developed.
And I will like to recorrect it rather than Bill Gates, we'll call him as Jeff Bezos. Over to Rajiv, sir. We are not able to hear you.
Rajiv.
Sir, kindly unmute yourself, please.
Can you hear me now?
Yeah, now it's better, sir.
Perfect.
Go ahead, sir, please.
First of all, I must tell all of you that I have learned more in this single webinar compared to what I have learned by attending 5 days of an international conference. We know Brazil for Pele, we know Brazil for Neymar, but for the first time I have understood that Brazil should be known more for Dr. Neto than for anybody else. What phenomenal skill of nucleus rotation. Congratulations, sir. We have seen beautiful in-the-back snare technique. We have seen wonderful videos from Dr. Mekur, Dr. Sahu, and everybody else. So thank you for giving me this great learning experience. Coming to my talk, it is on software-assisted SICS. I do SICS sheerly because I believe that the outcomes of SICS are better than outcomes of FECO in my hand. Maybe different for different people. I believe that a low pressure surgery, well controlled surgery, and a fortress incision, which SICS gives me, is not given to me by FECO, and therefore I do SICS. In SICS, I like to operate every case sitting behind the head of the patient, and my incision is fixed at 12 o'clock. We all know that a 12 o'clock incision will produce 1.25 diopters of astigmatism against the rule on a spheric cornea. This is the single biggest disadvantage of SICS. Now, I started thinking why this astigmatism comes, no matter where I put my incision, whether I go 3 millimeters behind the cornea, whether I go 1 millimeter behind the cornea, where I do a frown incision, whether I do a straight incision, I still get 1.25 diopters of vertical astigmatism in a spheric cornea. Now, if the patient already has a pre-existing astigmatism of 1 diopter, then I'm going to see astigmatism of 3 diopters after surgery in 90 degrees, which is a total disaster. Therefore, I studied why this happens. And then I realized that the vertical cornea is shorter than the horizontal cornea. Because of this, as you can see in the picture A, the vertical cornea is more tightly curved compared to the horizontal cornea. And that's the reason why incision in the superior meridian, according to me, gives more astigmatism, because when you cut this cornea, it snaps more, it gives more. And that's the reason for astigmatism against the rule in SICS in 12 o'clock incisions. Now, I'm not ready to change my incision. I don't want to go temporal, nasal, lower, higher, because it doesn't feel comfortable. The sclera is not symmetric. If you go temporal or nasal, it's very difficult sometimes to change your chair. seating arrangement of the staff, I'm more comfortable keep my incision at the same place. So what I did was, I learned why more astigmatism in 12 o'clock, and it was because of the tighter cornea, the shorter corneal curve in the vertical mirror. Now, if you look at Gauss and the principle that he believes in, that he has proven, then if you stretch the horizontal meridian of the cornea, then the vertical meridian will relax. When you have a relaxed meridian, you cut it, the elastic fibers do not gape, and therefore you get no astigmatism. So I built a software system which will tell me how much to stretch the horizontal meridian so that the vertical meridian is totally relaxed. Now, if you look at this image, the spring-like force which is acting on a perfectly spherical cornea owing to shorter vertical diameter is the green arrow. Now, what the system will tell me is how much should I stretch the cornea horizontally so that the vertical meridian becomes totally relaxed. Similarly, if the patient has a starting astigmatism which is oblique, then the system will give me a different output. I have been given only 3 minutes, so I will straight go to the video to show how this software works. This works with an illuminated keratoscope. There is an artificial intelligence into this system, so it filters out all other colors and images of the eye, and it purely reads the image of the keratoscope. I will fast forward it because I have to stick to 3 minutes. You can start it from here. I just explain. This is the image of the keratoscope, and the image of the keratoscope has been detected by the software, and now it is telling me how much to stretch, which meridian to stretch, and this is announced online when I am operating. So now it's telling me I have to make this at 40 degrees. Now what I'll do is I'll give posterior pressure on this blade so as to distort the image of the keratoscope and manipulate the corneal shape. This will relax the meridian where I am incising by flattening the meridian which is opposite to it as told by the system. So I have entered at 48 when it was asking for 40. This is reading the current. This is telling me how the current shape of the cornea is. We'll go forward quickly. Yes. Now I'm ready to extend the incision. I have perfectly matched the red line over the green line, and this is the perfect endpoint to take the incision. Once the incision is taken like this, the astigmatism, the expected astigmatism is expected to be 0 irrespective of the starting astigmatism in the system, in the eye. Now there are we've got very good results with this software. There are two important things that also are happening because of this. One is there is a reduction in angle kappa in 29 out of the 30 cases that we have seen. Second, because of this reduction in angle kappa and the Stiles-Crawford effect, we are seeing much better near vision in these patients compared to the earlier cases that we have done without using this software. This is uncorrected near vision. So it's almost 90% of the patients are definitely getting better than 6/9 and N10 vision, with which the patient can see his mobile phone and he is very happy. As I have only 3 minutes, I have tried to finish my topic here. Thank you very much for your attention.
Thank you
much, Dr. Rajanath. That was on par with any FACO, or I should be saying more than a FACO. I would like to hear some words from Dr. John.
Thank you very much for presenting. I think that was very interesting. And again, transitioning from SICS, dealing with very dense, very hard cataracts to becoming a refractive surgery, like you had mentioned. In the U.S., we have, in most of our ORs here, we have great access to an ORA machine. Do you think there's any way that we can use an ORA to check some of these measurements as well, to run it through, or is the software that you have readily available to use elsewhere?
ORA software, ORA wavefront card. Yes, the ORA depends on the wavefront, whereas this purely depends on the corneal. It purely depends on measurements of corneal system. Secondly, the ORA tells you where to move your incision, whereas this keeps your incision fixed and just distorts your cornea, tells you how much to distort the cornea, in what angle, so that the meridian of incision is totally relaxed. So they may be doing a similar thing. Secondly, the ORA costs a hell of a lot. I think 60 lakhs? ORA costs hell of a lot. This only costs $5,000. The most important thing is the exactness and the repeatability has been tested over maybe 4,000 or 5,000 cases, and it really works. And now we are building a robo. We are building a robo which will directly talk to the computer and give us the perfect corneal shape without giving any pressure anywhere on the incision. And then the surgeon just has to press a switch. Once the software takes over, the software will talk to the robo will distort the cornea, give us the perfect shape, and then you just go and take your incision. That's it.
Perfect. Perfect, sir.
Technology. Thank you.
So if we want to use this, so when is it available, sir? I know you have a patent pending on this.
Actually, I don't have a patent pending on this. There is our research institute, our non-profit institute for which I work, has the patent. I have no commercial interest in this product. We are holding workshops, and already 30 people in India are using this system.
Great. Thank you so much. And does any of the panelists have any questions? Please go ahead.
I think I'm using this system also, and I'm keeping a close watch on the results. So I will corroborate that many of you, he is giving it free of cost. If you are not happy, you can return the machine. So anybody interested can take the machine from him, and with a promise that if after 3 years, if he is not happy, 3 months, he is not happy, he can return the machine. So he is encouraging people to get used to it.
That's really so kind of Raju, sir, to give up do it off freely.
I think Dr. Jagannath sir wants to say something, and then Dr. Chinmay. Boramani sir, are you there? Yes.
Hello, can you hear me?
Yes, sir, please.
Hello.
Yes, sir, we are able to hear you.
Yeah. Sorry, there is electricity suddenly gone at my place, so I am through mobile now. I have been using this system. Dr. Rajanath has given to me also. I am one of the users. I have done about say 10 to 15 cases, but this has got a small learning curve. But in almost 50% of the cases, I have got the expected results. Patient has got very good near vision. So this is a wonderful technique. It requires a little learning curve. Only because of the pandemic, now we don't want to spend much time in the operation theater. So during the COVID era, now I have stopped using it for the time being, because for a beginner it takes little more time before taking the final incision. You have to spend almost 3 to 5 minutes. But if we get a knack of it, I think it's hardly half-minute job. So this software is a really wonderful tool, and without using a multifocal IOL, without glare and halos, in most of the cases you are able to achieve a good distant and reasonably good near vision. Thanks.
Yes, Dr. Chinmay.
Dr. Rao, wonderful innovation, very impressive, sir. Just a few basic questions. What is your recommendation for the IOL that has to be used in this surgery, whether because you're trying to give a distant as well as a little bit of near vision in these patients? Secondly, does the software also recommend placement of incision, the length, and other things? I mean,
second question first. The incision is always at 12 o'clock, 1.5 millimeters behind the conjunctival insertion on the cornea, and it's a mild round 6 millimeters incision. This is the first. The second question about the IOL power. We have
type of IOL.
I use a simple monofocal IOL, foldable IOL made by Rainer or one of these companies, and I do not make any change in IOL power to get better near vision. I feel the near vision gets better because of reduction in angle kappa and the styles property.
Ravindra sir, you have any comments?
Amazed by Rajiv. He's he thinks beyond what others can think, and he's fast ahead of the present era. And I know every one of his innovations is a genius, and for various reasons I have not adopted his technique. I'm keen to learn from him and adopt his technique, and we look forward to
Ravindra, thank you so much. Thank you so much.
This is not the only invention he has. Many half a dozen inventions he has. You can list them. He's the first fellow who started using chloroquine into the eye. There are a lot of them. He uses to kill the. He doesn't have PCO at all. It's eliminated in one stroke. Uses UV light to irradiate the endocapsular area, especially. You can tell more about the Brazil people, other innovations.
But please unmute yourself.
We have made a very low intensity ultraviolet light source which carries very low intensity ultraviolet light under the anterior capsule through a fiber optic. The intensity of ultraviolet light which is carried by this fiber optic is less than the ultraviolet light which is present in the microscope light, but it is presented to the anterior capsule from the opposite direction. When you touch the anterior capsule with this ultraviolet light, all the epithelial cells can be taken out in one layer as if you are doing a capsular excis. Once you do that, there are no cells left sticking to the anterior capsule, no fibrosis, no multiplication of the epithelium, no capsule opacification, no capsule contraction. It also works quite well, but I was given this topic, so I would like to discuss this. Yeah, thank you very much. Ravindra, thank you. Few words of encouragement from you are a great thing to have.
Thank you.
Okay, so anybody has any question before we come to the end? Any take-home messages any panelist wants to give? Yes, quickly, one word from Jeff, Pamela, Dr. Haggie.
Not there.
Yes, sir. Thank you. Everyone needs to continue to recognize that you have an ability as a surgeon to grow and advance our profession and improve your skills. Just want to thank all the leaders and vanguards here for how much I learned today. Thank you.
Dr. Pamela.
Thank you very much. It's always a pleasure to learn from the experts. They were amazing videos today, so I hope you can all share them so we can keep on showing these videos to a lot of people who I'm sure it's really interested in this technique. Thank you, Dr. Sahu, for always organizing these kind of amazing webinars. Thank you, everybody.
Dr. Haggie.
Thanks again for the invitation. This is my second time in your webinars. I think it was one of the best webinars I've attended in this COVID-19 era.
Dr. Boni.
I look forward to seeing everyone hopefully sometime very soon, and I give my best to everyone in all the other countries. Hopefully you and your families stay safe, and we can all continue to practice medicine and help people, but the best to you and your families.
Thank you. John?
First of all, what an honor to share the stage with such brilliant surgeons and leaders in the field. I really appreciate you extending this invitation to me. I will say I was able to learn a lot more than I was able to contribute. But again, I look forward to subsequent meetings and look forward to meeting you all in person someday. Thank you.
Thank you. Dr. Zubair and then Dr. Nito.
Yeah, my biggest take home for today is how much we can learn from each other and how much I desire to go to India to learn these techniques from these esteemed colleagues. It's been an honor. Thank you so much for the incredible presentations and the invitation to be here.
Dr. Nito?
Well, I can only thank for the opportunity to be here and learn so much for such skilled surgeons. Amazing. And I look forward to be participating in another meeting. Thank you very much.
And we are looking forward for the chapter launch in Brazil coming this month. And I think I'll share the link with you all, and we'll all be excited to have our first ISMSICS webinar from Brazil. Yes, sir,
14th November.
14th November. Yeah, wonderful. And thank you, Susan, for showing your beautiful house for us. And finally, we are all with, listening to you, we are all with Joe Biden now. So your last words of comment, Dr. Susan, other than voting for Dr. Joe Biden, Mr. Joe.
Yes. Okay. So first of all, what an amazing society. I'm so honored to be part of it. You are also brilliant. I am extending an invitation to every single one of you to help us in sub-Saharan Africa. We need your education. We need your brilliance. And please contact me directly. I'm actively working there, and Jeff Petty is very active, and we need you. Secondly, on behalf of the United States of America, I'm so sorry about the last 4 years and Donald Trump, and I hope we change the world soon by electing the correct president. And thank you so much for being part of this.
You're openly telling it, really. Fantastic. Suhas sir, any last comments, sir?
Well, no word should be complete. What started as a dream from Amulya and all of you, it's a fantastic. Today's webinar was so much educational to me too. Although I was doing SICS several years back, but today when I see Jagannath, you, MS Ravindra, all of you doing such wonderful work, I can only congratulate you and wish that this society grows bigger and bigger.
Thank you, sir. Dalit sir, your last comments, please.
No, just wanted to congratulate the organizers for a wonderful event. Each of the 12 talks, I think something learning was there. You can imagine if a vitreous retina person can sit through 2 hours, what does it speak about the content of the webinar? And one final word of advice, or maybe some comment to the office bearers, that rest not till you achieve your objective. That is 194. That's a challenge for Amulya Sahu and all the office bearers, because it's such a fantastic technique. And as Rajiv said, you see, we didn't learn so much in so many days of webinitis. But in this 2 hours, I think there was great learning. Yes, I agree with what Rajiv said. Great.
Thank you, Lalit sir. And quick comments from MSR sir and Dr. Deepak Nehru sir.
It's an amazing. We congratulate United States for starting its own chapter, and under the Sahu Amulya is, he will not take rest. 24 hours is just not enough for him to work on his. This has become his breath, his water, his food, everything is precisely for the whole team, for you and for Ramni. Another strong reason why we should be doing SICS is when I do SICS, however much it's complicated, anything may happen, my pulse rate will not go up by just 1. So that's the confidence you will develop when you are dependent upon your own fingers rather than the machine, which operates from the brain. It goes to the spinal cord, wherever it is goes to your foot, and then goes to the machine and then activates. It's a long circuit. Here I have in my hands. Nothing can go wrong as long as you as an individual is in control. It's a beautiful one. And the other thing is, you will not get Alzheimer's because there's no tension. It's absolutely fine. You are creative. It's an art. Cataract surgery is an art, and you're executing it. You're enjoying the surgery. that you're doing it. This is a message that I would like to give it, especially to the youngsters who listen to the trade, who listen to the industry and become slaves of the machines. So this is a small note that I would like to end up my talk and this beautiful workshop.
Very nice, MS.
Sir, we'll do a study, studying a pulse oximeter with a surgeon operating on the SICS and on the PACO, and we can even keep the ECG leads to look into the heartbeats as well. We'll do that, sir. I think Vajip will find hands with me in doing this study. Thank you very much, MS sir. Dr. Deepak and Dr. Chinmay, please, quickly.
I think a message to the ophthalmologists, cataract surgeons worldwide would be, I don't think we have any excuse for not learning SICS, whichever country you belong to. I think it's a quintessential technique that every surgeon should learn and master it, because it bails us out in many tricky situations, even if you're primarily a phaco surgeon. And I'm proud that I'm associated with this wonderful organization, and it's headed by the infectious president, Dr. Sahu, whose infection you just catch it, So again, thank you for the opportunity, and also thank all the international speakers who contributed it, and it was a great learning. Thank you so much.
Dr. Chinmay? Dr. Chinmay, your last comments, and then we'll wind up. You have to unmute yourself, Dr.
It was a great meet. It was wonderful listening to such a amazing amalgamation of speakers. Just something closer to home, because my father has been at the helm of popularizing manual small incision surgery. Being a high volume phaco surgeon, there's always a dogfight at home, with he more in favor of phaco and he more in favor of MSICS. I would like to end by saying it has been an honor to be seeing him operate, and the way he says that you have to be a complete surgeon, whether you do a MSICS or whether you do a phaco. At the end of the day, be a master of all. So that has been a great.
I would also like to say something.
Yes, sir. Dr. Chinmay. Yes, Dr. Rajiv Singh.
I just wanted to emphasize on the fact that there needs to be a complete surgeon. You need to learn the SICS technique. It can help you in complex situations. So,
Chinmay, who is more often the winner in this fight?
But that cannot be told publicly.
Be very honest. No. What's the harm?
So we end with saying whatever works best in your hands, you should be doing it. But at the end of the day, you should know, at least be comfortable with every technique so that you can use it to the best of your advantage.
Great.
Yes, Rajiv sir, you wanted to say something.
Yes, I would like to tell all the young surgeons who are attending that if you want, I am a private practitioner. I want to tell all the young surgeons, if you want to be successful in private practice, the most important thing is don't make complications. And if you don't want to make complications, only then succeed, because a good patient will tell good about you to one person, a complication will tell about you to 13. It's a ratio of 1:13. If you want to be successful, don't make complications. If you don't want to make complications, you do SICS, because SICS is a controlled surgery. This is a humble advice to all young people and who are starting you in private practice. Thank you.
Sure. Thank you. Boromani sir, yes, Susan madam, we can definitely do a webinar for East Africa. If you can host it, we are definitely for it.
Yeah. This is for everyone as well as the audience. ISM SSS is holding biennial world conference. Last world conference was held in Calcutta. Dr. Boni was our invited guest in that conference, and that conference saw the live surgery of software-guided SICS by Dr. Rajiv Rao. And hopefully now Rajiv is working very hard on the robotic SICS surgery. And in our next conference, which will be held in Chandigarh in September, most probably there will be live demonstration of robotic smart SICS surgery. So I invite everyone for that conference, CCC 2021. It will be in Chandigarh, India. Yeah.
Yes, sir. I think we welcome you all for that, and we are eagerly looking for that, as Boromani said. Yes, Susan, madam, you wanted to say?
I want to say one more thing. You are all, KOLs. You are key opinion makers here, and we need you to keep your voices loud, because there are many people paying attention to what type of technology is the best. And we need your voices in sub-Saharan Africa. This is a developing area for industry to get their hold on this. So every ethical comments you've made, we need you to speak up because it's a safer surgery. It is, and there is the misconception that phaco is better. And so people want to learn phaco because they think that is the technique that is superior. Please keep this work up.
Thank you very much, Dr. Susan. Points well taken. And before I hand over to Dr. Jagdish for last vote of thanks, I must say that it was a fantastic webinar. More than 3,000 viewers already into that. Successful international launch. And of these, I've been attending so many webinars in the AIOS as well as in the ISM-SICS and various others. I must admit today that ISM-SICS has a Midas sponge. I don't know how. Any program is being launched, I think it's all thanks to Dr. Sahu and Dr. Boramani. I think they have a Midas touch on that, and that's how these programs are being so great and so successful. And I'm sure that most of us will be benefited from the excellent presentations that we have learned from the plethora of the ophthalmologists around the world here. Thank you very much and good night, and over to Dr. Jagdish.
One point before Jagdish tells, this journal is getting published in the end of this month. I want all participants to contribute to that e-journal so that you come to know we remain connected on this front. Thank you so much. Jagdish.
Thank you, sir. Thank you. It doesn't start without saying thanks to Dr. Amulya Sahu, sir, without whom it would not have been possible. I also take an immense pleasure to thank all the ISM-SICS bearers, Dr. Boramani, Dr. Bhattacharya, Dr. Parikshit, Dr. Sutanshu Mathur, Dr. Srinivas, everyone who are the backbone for this organization. A heartfelt thanks to all the panelists who took out their valuable time, Dr. Lalit sir, Dr. Chinmaya, Dr. Pamela, Dr. Ansari, and Dr. Danson. Thank you so much for being here. And for the speakers, it was really, really great having all of you over here. Dr. Boni, we have learned a lot from your lasso technique to the loop technique of Susan, and which surgery to decide from Jeff and John to the flange clearance expression of Dr. Hagi. And that nucleus rotation really reminded of the Role in Vegas. And I would like to really thank Dr. Amulya Sahu for his excellent 2mm SICS surgery, along with the customized incision taught by Dr. Boramani, and that smart incision surgery by Dr. Rajiv Rawat. Needless to say, that topical phaco section by Dr. Ravindra was amazing, and that handling of that weak zonios by Deepak Mahur was astonishing. And last but not the least, Dr. Suhas sir put life into those iris by a wonderful iridodialysis repair. Thank you all. Thank you for making this happen.
And thank you, NTOT, for conducting all the ISM-SICS webinars and making it so grateful and so international. Thank you very much, NTOT, for this.
17th webinar.
The 17th webinar.
Yeah.
Great. And I think we'll go on with one more hour. I think most of the speakers are looking so, usually at the end of the webinars, they look so tired, but this is one of the webinars I'm seeing that energy is just growing and growing. I don't know how. I think we should come to an end.
Magic.
Magic by Dr. Sahu.
Do yoga.